for that kind introduction. I would also like to thank the organizers, and especially Clive. This is my 12th invitation to the conference, and I've had a challenging title every single time. I'm always enthused to read what the subjects are of each speaker's titles, mostly just to figure out from that title, what are you going to talk about? I think for my subject matter this year, I was quite happy with what Clive gave me because I went to the literature immediately and actually found material this time, Clive. So thank you. Okay, so what I'm going to talk about today, basically, today, is it possible to consider that we may have a generation, particularly in this case of children, that may be born without HIV? And so from that perspective, I'm going to discuss, obviously, PMTCT programs and the massive improvements and successes that we've achieved already. In doing that, I'm going to review a little bit. I think it's worthwhile to kind of go over the history, but just very high level. I'm not going to go into any details. Most of you are aware, but I think it kind of sets the stage with how far we've come with treating moms to treat babies in order to prevent HIV infection. And then we'll talk about the steps, programs that exist, the major effort by the global plan that is essentially worldwide. And then if we're going to treat moms, we can't forget that there's going to be kids left behind. And what are we going to do with the kids that are left behind that are HIV infected? How are we going to take care of those boys and girls? And then lastly, get back on track with the current status of the PMTCT programs and what it's going to take to reach all infected moms to prevent a generation from being infected. So as most of you are aware, the first case was described in 1982. I was studying pediatrics at the time, and this was a fascinating new immunodeficiency disease. We had absolutely no idea what it was. It was 18 months after the first cases had been described in adults, and I remember my first publication was in the MMWR, which is a weekly publication out of the CDC, and it presented the first 4 cases. What was immediately apparent was this is a drastic disease in these children. There were 4 cases. 3 of them were dead by 8 months of age. They reported in another 3 cases that had similar symptoms that didn't quite fit all the criteria that they were going to put into their case description of this new disorder. No idea what this was. This is 1982. What's unique about pediatric AIDS is it's not like adult disease, right? So the thing that was obvious right away is that this disease was coming from moms. And so transmission occurs during pregnancy, peripartum, and postpartum. We figured out very quickly that the disease could also be transmitted through breast milk. So prior to the development of any antiretroviral therapy, we knew the transmission rates. We had already studied the transmission rates. They were up to 25% with no breastfeeding and up to 40% in cohorts that had been breastfeeding their children. We also quickly figured out that maternal viral load any time during the sequence of during pregnancy, peripartum, or while breastfeeding was a strong predictor of transmission to the baby. We also figured out very early that if mom's viral loads were low, transmission rates were low. So this is already giving us a clue that if we can virally suppress the individual that's infected, we can reduce transmission. So one of the greatest public health stories was clinical trial 076. And again, we had one of the largest pediatric cohorts that was involved in this publication at Northwestern University Children's Memorial Hospital. We followed about 350 infected moms in this clinical trial. And the results were dramatic, and it generated a lot of excitement. It's often referred to as clinical trial 076. I think a few of the speakers have alluded to it already. It was, again, extremely indicative of potential to eliminate infection in children very early on. So we're now only 12 years out from the original case cohort study, and we've already figured out that there's an invention that can reduce infection in children. So this is the results of that original trial, the 076 trial, and you can see very clearly a reduction of 70% of the infections in our cohorts. This was very exciting times for us. Furthermore, as the evolution and the development of the drugs progressed, we progressed in the regimens that we were putting our moms on, and we saw increasing ability to prevent transmission to the baby. We didn't know it at the time because the sensitivity of our viral load testing wasn't that high, but we did know that the higher viral loads did equate to transmission At the time, the undetectable viral loads were not related to transmission, so we were protecting moms if we could get their viral loads suppressed. So these regimens were rapidly adopted in the United States to the point that within the last 10 years, from my institutions in Chicago and Los Angeles, we have not had an infected baby. So this is a remarkably successful program within the United States. So after the 076 trials were released, obviously now we need to start treating internationally. And so this is what started to happen. The 076 result trials were published. We immediately got involved. ACTG, the AIDS Clinical Trials Group in the United States, had to expand their reach and started to expand internationally. And this is where we started to see the adoption of the single regimen trials internationally, and again, starting to affect the rate of transmission internationally. So slowly, these international trials built on successes in the West. Additional drugs started to be adopted. Success continued to escalate. At the same time, based on outcome studies, the WHO was publishing their guidelines. And as you heard today, we're all pretty serious about following the WHO guidelines. And as my lectures over the years, I've presented all of the guidelines up to the 2015 guidelines, which I presented last year. And we'll talk a little bit more about that as we go. But what about the breast milk? So in the US, we had a solution, right? We have really effective replacement feedings for children. We just say don't breastfeed, right? Use formula feedings and you'll prevent transmission via breast milk. That's okay for the US, but we know that greater than 90% of the pediatric infections aren't happening in resource moderate or resource-rich countries. They're happening in resource-limited countries, greater than 90%. So what do you do in resource-limited countries, right? We could ask them to not breastfeed, but in the first clinical trials where we did that, it directly affected survival. In resource-limited countries, the primary feeding method may be breast milk, so you can't really eliminate it. So it really became the turning point in the pediatric epidemic of HIV infections when we figured out how to treat moms to prevent transmission of the disease while breastfeeding, either by treating the mom or prophylactically treating the child to prevent infection. And the results of recent clinical trials have clearly shown that this is an effective way to prevent transmission through breast milk. So here we are. We have highly active antiretroviral therapy to treat mom during pregnancy, peripartum, postpartum, prevent transmission. We're now getting down to rates that are below 5%. Now we can start thinking, we're not preventing transmission to children, we're eliminating transmission of HIV to children from infected moms. So a generation of children without HIV, this is probably the largest concerted effort that we're going to see in our generation to try to effect the elimination of pediatric HIV from infected moms, the global plan. And we've heard bits and pieces of this through the whole conference already, and we are going to hear more. This has been an extremely successful program adopted by UNAIDS in collaboration with the United States. 30 countries were involved in the original discussions. However, it covers every resource-limited and every resource-moderate country with a focus on 22 of the primary countries with the highest prevalence of HIV. So there are 4 prongs, and this is again the 90-90-90. So prong 1 is to reduce incidence, HIV incidence in women of reproductive age, 15 to 49, by 50%. Prong 2, reduce unmet need for family planning to 0. So one of the unmet needs that we are experiencing even today is family planning amongst women of limited means in resource-limited countries. And we saw the effectiveness of combined prevention. Family planning is huge in terms of reaching women, reaching families, and understanding family planning needs. Prong 3, here's your 90-90-90. Reduce mother-to-child transmission of HIV to 5%. 90% of mothers receive perinatal ART or prophylaxis, and 90% of breastfeeding infant mother pairs receive ART prophylaxis. And lastly, provide 90% of pregnant women in need of ART for while they're pregnant and lifelong after delivery. So as this is evolving, the WHO guidelines are evolving in sync. And we already heard through the last 2 speakers, they're changing their actual studies in concert with the change in the WHO guidelines. As we're learning that if you reduce HIV to undetectable levels, you can prevent transmission. So the WHO guidelines have been evolving in concert with the global plan. So WHO continues in up to 2015 with dry blood spot testing, et cetera, earlier diagnostic testing, earlier antiviral testing, and more potent and more tolerable drugs, as we heard from Réjean earlier this morning. So the WHO clearly supported early diagnosis using dry blood spots for access and reach into hard-to-reach communities, eliminating the need for the transport chain, cold transport again. That same year in 2010, the guidelines came out saying, with the results of the SHARE study showing that earlier treatment improved morbidity and mortality, they changed the guidelines to all children less than 2 should get treatment. And then as we know, in 2015, the WHO upped the guideline, upped the ante, all HIV-infected children should be treated. So that's where we are today, right? If we're gonna succeed in this plan, the global plan outlined the needs that every country has to implement. And these are country-specific recommendations. And I don't think you can read this, it doesn't really matter, but I'm just gonna summarize in order. You need strong leadership. All of the successes can all go back to strong leaders. Whether those were government leaders, a physician leader, an advocate leader, you need strong leadership. And that leader has to be willing to go to places where other people haven't been. They have to be willing to take flack. You have to be able to fight with the government. You have to be able to fight with activists. You have to be able to fight with physicians if you want to disseminate treatment to nurses. The physicians don't like that very much. I mean, at every stage you need strong leadership. You always need an up-to-date national plan. I mean, where are you going? If you don't know where you're going, it's unlikely you're going to get there. Financial investment, you need for a comprehensive, coordinated approach. When we talked about this, the comprehensive, coordinated, and multifaceted approach to HIV prevention and treatment for mothers and their children. Greater programmatic synergies between the health system, the vaccination for children, teen clinics, family clinics. We need greater synergy. We need greater human resources, and we've heard that in the last lecture where we had the CHIPS program. I mean, these people require training and resources and intervention. You need to address structural impediments to scaling up. We heard that from the Barbados question earlier today. How do you get to the next level? You're not funded for it. You haven't developed a program for it. You're going to go from reaching 50% to reaching 70% to reaching 90%. This is scale up. This requires change in planning. You need to strengthen access and essential supplies. We can't have stockouts. You have to plan ahead of time. Planning ahead of time requires good data, right? So if you have the data and you know your population, you can plan ahead of time. And then lastly, we need to simplify our strategies. Simplification results in less errors, less problems, and improved opportunity for success. So those are the 9 key needs that the countries need. The conditions to drive progress are all outlined in the global plan, and I'm going to summarize them very quickly here. All women, especially pregnant women, have access to quality, life-saving HIV prevention and treatment for themselves and their children. The rights of women living with HIV are respected and empowered to ensure their own health and the health of their children. Adequate resources, both human and financial, are available from both national and international sources in a timely and, again, predictable manner, while acknowledging that success is a shared responsibility. Yourself, your national and international support. HIV, maternal health, newborn child health, and family planning programs, and we talked a little bit about this synergy. The more combination, the more dissemination, the more local treatment that you can provide, again, increased chances for success. Communities, particularly women living with HIV, are enabled to empower and are empowered to support women and their families to access HIV prevention, treatment, care, and support. And again, this is establishing that support mechanism. And lastly, national and global leaders act in concert to support country-driven efforts and are held accountable. And this is a little bit different, to holding our sponsors at a country national level accountable for the results of our projects. So where are we with treat early, treat fast? We now know, and we've seen the outcome in the trials presented today. It not only reduces the mortality, but it reduces morbidity, and we get to improved quality of life for the family. Combination antiretroviral therapy during pregnancy, we know now, is the most effective way of preventing HIV transmission. There is no better method to prevent HIV transmission from an HIV-infected mom to her baby. So these results what led to originally what was called, in 2001, a prelude to treat all, which was called Option B in the WHO guidelines from 2011. Option B basically states that we treat all HIV-infected pregnant and breastfeeding women, and they stay on retroviral therapy for the rest of their lives, again, leading to improvement in the quality of life in the family. So at this point in 2011, this had become standard of care already in many countries, and then now, as we know, with the 2015 guideline, it's standard treatment. So here we are, we have effective treatment, we have a way to do it, we have a guideline with the global plan, what are countries doing? The first publication to come that had adopted Option B was out of France. About 2,600 infected women receiving HIV therapy according to the guidelines during pregnancy, following pregnancy, not one infected child. So this is dramatic evidence that this approach to prevention of mother-child transmission is effective, and we may be looking at eliminating mother-to-child transmission. So this is just to restate what Catherine Vizuriaga and Lynn Mopinson said, who are, as far from my perspective, I've been working with these two women for 25 years. They are the champions of pediatric HIV infection. And again, it's not only possible to consider reduced, but elimination of mother-to-child transmission, even in settings where resources are limited. So how do you know that you have eliminated mother-to-child transmission? And who do we look for as the guidance on this principle? So it's probably a surprise to no one that the WHO has published guidelines for statistics on how to measure if your country has eliminated mother-to-child transmission of HIV. So this is the reference if anybody's interested. We can certainly get you an electronic copy of it. So basically the WHO has published the criteria and the process for validation that your country has eliminated mother-to-child transmission of HIV and syphilis. This is the definition. Fewer than 50 cases per 100,000 live births. And in deference to both of the earlier speakers, you're going to see that they've changed the targets on us. It's not 90, 90, 90 anymore. It's 95%. Okay? And so transmission rate below 5% if mothers are breastfeeding, and transmission rate below 2% if the mothers are not breastfeeding. An awareness of HIV status among more than 95% of pregnant women. So it's no longer 90%. We're upping the ante here. And the same with the receipt of antiretroviral medications by more than 90% of pregnant women with HIV infection. So if you reach these targets, the WHO will certify you as having eliminated the transmission of HIV from an infected mom to a baby. And these are the results in Africa of the implementation of the global plan between 2009 and 2015. In the United Republic of Tanzania, 69% reduction in new pediatric infections, and 86% of the women are now receiving ART. In Zambia, 69%, in a population of 1.4 million HIV-infected persons, and 87% of the pregnant women receiving ART that are HIV-infected. And in Zimbabwe, new infections in children reduced by 75%. Uganda, in 2015, 95% of pregnant women living with HIV received ART. Reduction in new HIV infections in children by 86%. And in Ghana, success, not quite as much success, but a 49% reduction in new pediatric HIV infections. It's happening, okay? This is exciting to see this, okay? This is published both by WHO and UNAIDS on the front pages of their websites. When you turn it on, this is what comes up. July 2015, Cuba is the first country to receive WHO validation, the elimination of mother-to-child transmission of HIV. Is it possible? It's certainly possible. Is it the whole answer? We heard yesterday, by no means is this the answer. We're seeing the same decline that we're seeing in the transmission to children. We're seeing increases in other populations. So Cuba, I mean, if you want to read, there's a really nice paper that publishes why Cuba was successful. They have provided enormous amount of resources to the care and treatment of pregnant women. So much so that a woman can move to be next door to a hospital, a woman can be admitted to a hospital if they're HIV infected. They really targeted PMTCT program to the point that they're the first country to be successful in eliminating mother-to-child transmission of HIV. And there's more. So Thailand is the first country in Asia to validate elimination of MTCT, meeting the WHO targets. And then Belarus received validation as having eliminated MTCT. and then Armenia. And so, as I said, these are on the front pages of the WHO and the UNA's website. So it's pretty exciting stuff. So this is success, but what about those children that did get infected? Okay, this is something that we will have to address if we're going to consider a generation of children, especially without HIV, right? So even if all countries could achieve 95% coverage of infected moms and their infants to eliminate new infections, it's estimated that we would still have 2 million children living with HIV. We also know that infection in children is drastic. Perinatally infected children do very poorly. In Africa, we know from the outcome studies that after 18 months, 70% of the children will be dead without any treatment. So we have to get to the children, we have to treat the children. We also know that perinatal infection is much worse than those infections that are acquired later in life when the child's immune system has developed somewhat to more maturity. This is the SHARE study. This was the evidence ultimately that led the WHO to say treat all. And so the first review of the study showed a dramatic decrease in the rates of infection in the death rate of children that were treated immediately upon detection of their status. So we now know that the 2008 randomized SHARE study ultimately led the WHO to change the guidelines, initiate early HIV infection, and immediate initiation of ART for all HIV-infected children, which are the 2015 guidelines in which we subscribe to today. This has resulted in some interesting observations that gave us a lot of hope that other than the Berlin man who had the transplant with CCR5 negative donor, we may be able to eliminate HIV from children if we treat them very early. This is the so-called Mississippi baby. And I remember at this conference when we were all excited and we were talking about, okay, we got to get all these kids on clinical trials, we got to start treating them immediately, we're going to get rid of HIV. None of them are not going to be infected. Once they are infected, we can get rid of it if we treat them very early. Unfortunately, that proved not to be the case. The child was treated for a variable period of time and was off treatment for 37 months before the virus rebounded. It led to other attempts at essentially a HIV or an art holiday. None of the kids that have been put on these programs, treated early and taken off, have been as successful as the Mississippi baby. And of course, what we're trying to do is figure out scientifically why is that. And so there are several things that have to be done to improve the nascent viral load in these children. So the viral reservoir, we know that if you treat early, the viral reservoir is much lower. I think I have a slide of that. So the earlier you treat, the lower the reservoir. So this is done by measurements that are kind of gross measurements. We also know by, and I think Phil alluded to this today, integrated DNA. About 100 to 1 of the integrated DNA copies in our genome are not functional virus. They will not generate functional virus. And so if we could measure better the viral load inherent in the CD4 cells of children, then we could maybe do more about that. So this is the first 3 children that got treated very early, and a summary of the results. And you can see that with the available technology that we have today, that is before Phil's lecture, none of these children had cell-associated HIV detected, okay? But every single one of them rebounded. So that means that HIV is present in these children, but we can't see it. So what Phil mentioned today, maybe we have a new method to potentially detect and measure the viral reservoir in children that have been on very early antiretroviral therapy. And it'll be very interesting to see if this technology gets adopted to research in children, and once we can measure it, we can do something about it. So for success in treating HIV-infected children, in order to further improve outcomes, we need to develop more sensitive assays to detect latent HIV. We may be there. We need to start earlier and treat longer with drugs that have better penetration to reduce the latent viral burden. We haven't been able to do that because we can't measure. The sensitivity of our assays are not good enough to see if any of the new retrovirals that are formulated for children can get at the reservoir. But now with the tool to measure and the development of new drugs, we may be able to get there. And lastly, what we know from these children is when we treat them very early, they never develop an HIV immune response. So if we're going to treat them, we need better drugs. We also need to stimulate the immune system with some sort of vaccine. And I know that there's a lot going on in this world. We've had very limited success with vaccine, HIV vaccine to date, but there's a lot of investment that's going on and trials that are going on to improve the ability to stimulate an HIV response. So if we're going to improve the treatment of HIV-infected children, we need better tests, we need better drugs, and we need to somehow stimulate HIV immunity. So back to elimination of mother-to-child transmission of HIV and HIV-free generation. We've heard this at least 5 times in this conference. The access to treatment from HIV-infected pregnant women is around 76%. It's not high enough. This is just the summary from the UNAIDS report showing that the level of treatment in children is less than half of all infected children, whereas we're about 74 to 76% in HIV-infected women. What's encouraging is the dramatic increase that we've seen since 2009, however. So elimination of new infections, and we have heard this repeatedly, we have access to antiretroviral drugs. What are we seeing? We can't reach the people to get them the drugs. We can't get them to come to clinic. We can't get them into stage 2. So even if we test them, we're not getting them access to care. And so it's going to take a lot more than drugs, and we've heard it over and over and over again, and the same applies to moms, right? So the number of new infections among women of reproductive age remains very high. We also know that acute infections in women that are breastfeeding are particularly drastic in terms of the rate of transmission. So women that are getting infected while breastfeeding, it's very problematic as far as transmission to children. And again, the unmet need has decreased. However, it's still estimated that approximately 150 million women still have inadequate access to family planning. So this is where the WHO has come up with the 95% numbers, right? So elimination of transmission requires a series of sequential interventions targeted to women and infants with 95% adoption. So we've gone from 90, and again, this is modeling, right? So we've gone from 90 to 95% now. And what they've estimated is that any reduction from 95% has profound consequences at each of the steps. And so the next slide is a series of the steps, and I think I'll skip that because I summarized them in the next slide, where I have each of the steps and where we're at currently. So pregnant women accesses prenatal care, right? We're at 77%, we saw that. Pregnant woman undergoes HIV test, 44%. Pregnant woman receives HIV test. We don't have the actual data for that. HIV pregnant woman receives antiretroviral therapy, and we saw this number. This is a success, but we've got to get the women in to get them tested. HIV pregnant woman is retained in care and adheres to treatment. We don't have that number. HIV woman delivers child in the presence of a skilled attendant. That's only 50%. HIV exposed infant receives 6 weeks of ART prophylaxis. Again, we saw that number earlier at 50%. Mom and baby linked to postnatal care. We don't have good numbers for that. Mom receives and adheres to ART while breastfeeding, right? Again, that's 39% that are not adhering to ART, that are at risk, potentially, even if they're not infected, of having an acute infection with very high viral loads and super high risk of transmitting to their child via life-saving feeding. Infant is tested again at 4 to 6 weeks of age, 44%. Infant is tested for HIV at 9 months and 6 weeks after cessation of breastfeeding. We don't have those numbers for children. Infant receives ART if HIV positive, 32%. We can do better, and we have to do better. So again, challenges at each of these steps, and we've heard this throughout the day, and is each of the steps that are required in order to get women into care and keep them into care to be virally suppressed. What is good and what is going to promote success is the consolidation of the treatment guidelines from resource developed to resource-limited countries. And I think this is the summary today of how you treat HIV-infected women in the Western countries, developed countries, versus how you treat women. And there are very few subtle differences. The primary differences being, in the US, we don't recommend breastfeeding if you're HIV-infected, whereas we do allow breastfeeding with prophylaxis in resource-limited countries. And then the testing paradigm for children is a little different between the two countries, but the treatments are now pretty much consolidated between the countries, which is simplifying the ability to adopt these protocols worldwide. So in summary, a generation of children without HIV, dream or reality. The global plan towards the elimination of new HIV infections among children by 2015 and keeping their moms alive really created the political environment that was lacking to get this done. So we now have support from the top, from the countries that want to adopt these guidelines, to allow them the support they need to treat infected moms. So although great progress has been made, there's still much to be done before mother-to-child transmission of HIV is eliminated. So even with the elimination, over 2 million children will be living with HIV, and today less than 50% are receiving ART. A number of initiatives stemming from the global plan are currently underway, with some of them coming to maturation this year. They draw attention to the needs of children living with HIV and to accelerate the development, production, and availability of priority HIV medicines for children. And with that, I honestly think that we could reach our target of ending AIDS by 2030. We'll have a generation of children without AIDS by 2020, but we will not have a generation of children without HIV by 2020. And with that, I thank you very much for your attention. And Clive, I thank you for all the opportunities you have afforded me to speak about things that I would never have spoken about otherwise. Thank you very much.
Well, could you just confirm, I may have been fast enough, if you have those infected children, is there a miracle combination of antiretroviral therapy which might be useful for them? They're already infected kids. Is there a non-toxic, relatively pleasant ART?
No, it's a very good point. Obviously, the population of children is not large enough to warrant the investment. There's not a market driving that development. There are, however, strong, in 2015, there were 5 government agencies that got together and have invested a large amount of money to improve formulations for children, the size of the pills, the combinations
exactly,
of drugs,
GIPS and the rest.
and
Yes.
increased ability to treat. And as I mentioned, we have to get rid of the latent virus if we're going to do something for these kids, to get them on so-called HIV remission. So the things that we don't know at the moment, the studies that still have to be done, how are the therapies affecting children in utero? I mean, there's not good outcome studies of children that have been treated with the antiretroviral drug versus those that have not been treated. And so we don't understand. I mean, it's an antiretroviral drug, but how we know from some of the side effects that we saw with these drugs in adults, these are affecting our children. There are not good outcome studies. And so there remains to be a lot of work in pediatric pharmacology for treating of children with HIV infection. I mean, as I mentioned earlier, we can't measure the reservoir. So it was undetectable. And yet, within 2 weeks, the child from Milan rebounded to like over 150,000 copies. And yet, so that's lurking somewhere. We need the technology to be able to, before you can develop the drugs, you need a metric, you need a surrogate of the resonant viral reservoir. And then we can start looking at drugs that may affect it. But until we can measure it, it's pretty tricky to say we do know that if we treat very early, the reservoir shrinks. So what we can measure, children treated late have very large reservoirs of HIV. That's been done. Those studies are published. Children that are treated early have diminished. Children that are treated very early have diminished. But then there's a whole population where we can't measure the reservoir. So how do you investigate and research better treatments when you can't measure the parameter that you need to measure? And so we may have a tool with the advent of Samoa.
Any further questions?
Yeah, that's still measuring the reservoir, you're looking at intracellular concentrations.
They're measured. There are 2 assays, right? There's viral outgrowth assays, and there's integrated DNA. We can sequence. I could sequence the genome of these kids and find HIV in the genome. The rate of productive virus for the number of detected HIV sequences, about 100 to 1. So for every 100 cells that have integrated HIV DNA, only 1 will generate productive virus.
So in the Samoa system, how are you going to get at?
I've been discussing that a little bit. It was kind of the question I asked them, right?
Yeah.
So you take peripheral blood, you have 1 million lymphocytes. Stimulate with all these drugs now that are forcing virus out of the genome. Then you measure the
parental
supersede.
and
So if you see nothing or not there, then put 10 million in, put 100 million in. Eventually you're going to get to a point where you're going to be able to measure the protein, which is functional virus.
what about my neck of the woods, above the neck, the brain? You know, parenchyma and
Very,
lymph
very,
nodes,
very good question. Very good
and,
question.
genital tract.
Very good question. I mean, we also know from studies of latent viral measurement studies that the earlier you treat and the lower the viral load goes, the lower the reservoir. So all the treatment now, the treatment of prevention with earlier prevention, earlier detection, we are going to lower the reservoirs. And maybe we'll limit access to more privileged immune sites. But those are all good questions, and there are no answers to them. Yes.
So in the cascade of perinatal coverage that you showed, you had numbers like 70%, 55%, et cetera. You'd have to multiply those all down. You would probably get something like 25% coverage. PEPFAR and WHO are saying we're hitting 80%. So they can't both be right. Would you please comment?
No, I agree. It depends on your denominator. I think it was you said it earlier. You have to look at the entire HIV infected population. That's the source of the epidemic. It's not the women on retroviral treatment, right, who are staying and being virally suppressed. Because you're ignoring the 25% that aren't out there. No, it's a very good point.